Hello, good afternoon, everybody. I'm Julie Ling. I'm CEO of the EAPC, and I also work closely with the WHO. I'm just going to introduce my colleague from WHO Geneva, Marie-Charlotte Bousseau, who is in charge of palliative care in the WHO office in Geneva, and who has had a huge influence and impact on the development of palliative care right the way through from the World Health Assembly resolution. So I'm going to just say I'm looking forward to hearing everyone's talks and to the webinar, and it's another example of a collaboration between the EAPC and WHO. So Marie-Charlotte, you're very welcome.
Thank you, Julie. And good afternoon or good morning to all of you. I'm actually delighted to welcome you on behalf of WHO for this webinar on economics and palliative care on the occasion of the Universal Health Day on universal health coverage. I'm very grateful to the collaboration we have with EAPC, and particularly for having this occasion today of dialogue on a very important issue. As you all know, WHO has a strong mandate since the adoption of the resolution on the strengthening of palliative care in 2014. And in this resolution, it's very clear that we all share an ethical responsibility to provide palliative care to the people who need it within the universal health coverage. So this ethical responsibility is the first reason why we are here today. But we also have other reasons. When palliative care is integrated in healthcare systems at all levels, starting with home-based care, it has been shown that it can reduce the use of costly and most of the time non-beneficial treatments, hospital admissions, ICU admissions for patients with advanced serious illnesses. So while palliative care is improving the quality of life of people, it can also decrease costs. We all know that healthcare provided during the last year of life is known to account for a large proportion of costs. So we definitely need to look seriously at the real benefit of what we do during this period of time for patients. And this is what our panelists will help us to do today. They will update us on new knowledge in this field. This work is actually a WHO initiative, which should conclude with the publication of a technical document, hopefully early next year. But I would like to take this opportunity to really thank all the members of this working group. They have been drafting this document under the coordination of Liz Guider, who is also moderating this discussion today. I think this publication should help policymakers to make enlightened decisions in this field. So I will now turn on to Liz, who will introduce our panelists, and thank you again for your active participation to this dialogue today. Over to you, Liz.
Thank you very much, Marie-Charlotte. I'm going to introduce the people who are the panelists this afternoon, but there is a whole team behind us who have been engaged in putting together this document, the paper that we call the Economics of Palliative Care. The first person to speak will be Eve Namasango, but Eve is not able to be at the webinar, so she sent a recording. She's the Programs and Research Manager at the African Palliative Care Association, an honorary senior health scientist at the College of Health Sciences at Makerere University, and a board member of the International Association for Hospices and Palliative Care and the Institute of Hospice and Palliative Care in Africa. We will then move to Eric Krakow, who has just flown in, and we are very glad to have you here. Eric, he's the Director of Program in Global Palliative Care and Associate Professor of Global Health and Social Medicine at Harvard Medical School. He's an attending physician, and I can see he is in his work clothes at the Division of Palliative Care at Massachusetts General Hospital in Boston. He's also the honorary chair of the Department of Palliative Care at the University of Medicine and Pharmacy at Ho Chi Minh City in Vietnam, and he previously worked as medical officer for palliative care at the World Health Organization, so closely with Marie-Charlotte. We have Dr. Eleanor Reed, who's an assistant professor in the Division of Global Health and International Emergency Medicine at Yale University, and her research focuses on global palliative care and is centered on defining the conditions and the context that make palliative care an essential, cost-efficient, yet missing component of care in emergency and humanitarian settings. And we have Jane Bates, whose expertise is in global palliative care and health economics. She has lived and worked in Malawi for 19 years, developing clinical teaching and research platforms in palliative care at Kamuzu University of Health Sciences in Malawi. We also have Richard Harding, who's the Herbert Dunhill Professor of Palliative Care and Rehabilitation, the Director and Global Lead at the Cicely Saunders Institute of Palliative Care Policy and Rehabilitation, and the Vice Dean International for the Florence Nightingale Faculty of Nursing, Midwifery and Palliative Care. And then I myself am Emeritus Associate Professor of Palliative Medicine at the Faculty of Health Sciences in the University of Cape Town, and recently have been working with WHO and coordinating the development on this paper, the proposed paper on the economics of palliative care. I'm going to start and share my screen now and give you Eve's introductory video.
Marie-Charlotte, thank you very much for the kind introduction. And I'll just share my slides. Thank you. So, costs of end-of-life care. I acknowledge my co-author of this chapter, Dr. Charles Normand. Palliative care, what it is and for whom. Palliative care is not about not doing anything, but it is patient-centered care for adults and children at all stages of incurable disease and an important component of universal healthcare coverage. And by patient-centered, I mean that the care focuses on the patient and family and not the deceased. And we have evidence that early palliative care improves survival and other domains of patient quality of life and well-being. So let's talk about the global economic situation. Globally, there is increasing pressure on health budgets. Therefore, planning for resource allocation to ensure both continued quality of care and value of health interventions is now pivotal to managing health budgets. And we know that out-of-pocket costs rise with advanced illness and disease severity. And this is why global economic situation issues are important to us in the field of palliative care. And costs rise due to need of medicine, need for investigations, hospitalization, at times admission to intensive care units, and also travel. And what about costs of care at the end of life? And the end of life is about the last year of life. And this care accounts for a large proportion of health costs in most health systems. And the high costs are explained by costly health interventions, some of which are non-beneficial to the patients at the time, high levels of service utilization, and then the cost of services. Because of the multiple symptoms, the complexity of the symptoms and concerns, these people need specialized care, which is very costly. And therefore, affected populations may experience financial catastrophes, loss of assets. Some children have to forego education. Adults have to lose income and focus on caring for their loved ones. Adults lose relationships. Some people give up on their relationships to go and look after their loved ones. And where children are involved, we predispose them to vulnerabilities. This is why some end up with teenage pregnancies and then high rates of HIV infection in resource-limited settings. And in Europe, 10% of people near the end of life are responsible for over 60% of the total end-of-life health and social care budgets. And this is some data from the WHO Global Health Expenditure Database. And this table just demonstrates that in resource-limited settings, there is a high financial disease burden on the side of patients. Governments only shoulder a small chunk of the expenses, and the rest has to be borne by the patient and family. And we see a difference when we look at developed countries. We see their governments funding the larger chunk of the financial costs required for care. And then we have an interesting scenario in resource-limited settings. Government officials have the privilege to receive end-of-life care in developed countries because our systems are less developed and palliative care services are less developed. And I'm showing the case of one controversial case which happened in Uganda, where a flight alone cost the country $500,000. And this government official needed caretakers, and also government had to meet care costs wherever they went for treatment, and it is their privilege because of their position. And it's been noted that government has to spend about $150 million a year on such care. And we now have a public outcry that we need to develop our services in country and put an end to medical tourism because we simply cannot afford it. And it also raises equity and social justice issues. What about the taxpayers who are not privileged to be government officials? Will they receive the quality care that they deserve? And we have some evidence from India that palliative care enabled 85% of patients and families to spend less on medicines, and also 31% of their patients received free medicines, and all patients reduced on use of outpatient service departments. And this is an indication of a reduction also in the amount of money patients spend on transport. And this is just with an intervention of palliative care. And then I'm showing the case for Kenya. The African Palliative Care Association and Kenya Hospices and Palliative Care Association have attempted to cost palliative care in an effort to include it in our advocacy agenda of ensuring that palliative care gets into the essential universal health care coverage package. And we've noted that for every $10 spent on palliative care, the benefits are $27. So ladies and gentlemen, conclude by saying that palliative care is a value for money investment and not just a cost-effective intervention. And I thank you.
Thank you very much to Eve for her presentation. I am going to now move to the rest of the slides and ask Eric Krakow to start on the main presentation. Eric, if you would just tell me when you want to advance the slides.
Okay, thank you, Liz. And you're right, I am wearing my work clothes, but these are my travel work clothes. I just arrived in Cairo, and I think I had a cardiac stress test because I told the driver I needed to get to the hotel very quickly. And well, my heart rate is now reduced to about 120 from 200. It was exciting, but I made it. So glad to be with you. And so I just want to say at the beginning that I think all of us understand very well, and it bears emphasizing, that the reason to do palliative care is because it's medically and morally imperative. But it turns out that it can actually save money for healthcare systems and prevent financial catastrophe for patients and families, as Dr. Eve said. And as we all know, governments tend to be most persuaded by financial arguments rather than medical or moral ones. So I'm very grateful for Marie-Charlotte Boisseau and Liz Gwither for organizing this technical brief and this webinar. Liz, how much time am I supposed to take? Am I already halfway through?
You have 7 minutes.
7 minutes, okay.
Would you like to switch your video on, Eric?
My video is on.
Okay, cool. I just don't see you, but I'm not quite sure why. So just let me know when I must advance your slides.
My video seems to be on,
okay,
but I'm not much to look at anyway. So thanks also to Dr. Eve and Dr. Marta Leon for working with me on this. Thank you. Someone can see me. So the basis of the essential package of palliative care was the work of the Lancet Commission on Palliative Care. And I had the great privilege of serving on that. Felicia Knoll was director. And my job, part of my work, was to identify the types of suffering, the severity and duration of all types of suffering, physical, psychological, social, spiritual, associated with serious illnesses, the serious illnesses that most commonly generate a need for palliative care. What do people suffer from exactly with each illness? And then we also estimated and used data from WHO and the Institute for Healthcare, IGHE, what's it called? Healthcare metrics, the number of people who experience this suffering each year in every country in the world. Based on those estimates, which were published by Lancet in 2018, we then created an essential package of palliative care designed to respond effectively to that suffering in most cases, and to be affordable and feasible everywhere in the world. The essential package of palliative care consists of a set of interventions, medicines, equipment, social supports, human resources, and standard operating procedures. And it's designed to be covered by government insurance. Next slide, please. Next slide, please. Okay, so the interventions are quite simple. Prevention and relief of physical distress, whether you're acute or chronic. Of course, if somebody else is dealing with acute pain, then palliative care folks don't have to. But prevention and relief of physical suffering, psychological, social suffering, spiritual suffering. Next slide, please. The medicines, as you may know, the World Health Organization publishes a model list of essential medicines for palliative care in its model list of essential medicines. But we actually boiled that down to what we thought were the most essential medicines for basic palliative care. And we selected these medicines based on several criteria: necessary to prevent or relieve specific symptoms or types of suffering most commonly associated with serious illness. Safe prescription and administration requires really only basic training in palliative care by doctors, clinical officers, assistant nurses, felchers, nurse anesthetists with basic or nurse practitioners with basic training in palliative care, and these medicines offer the best balance in their class of accessibility on the world market, clinical effectiveness, safety, ease of use, and low cost. Next slide. The equipment is a small list, but necessary for relief of at least one type of suffering, inexpensive, simple to use, and easy to store and ship. And two of the pieces of equipment I'll mention. One is opioid lock boxes. We've got to keep the opioids safe so they're not diverted or stolen or disappear, which can lead to greater restrictions on opioid access. And another is adult diapers to reduce the burden of family caregivers. Social supports were recommended at least for patients and their principal caregivers who are living in extreme poverty, at least. And they're designed to assure the most basic needs such as food, housing, transport to medical care, school, make sure the kids can go to school, and to promote dignity. And these typically should be funded not by ministries of health, but by ministries of social welfare, who tend to have responsibility for this. The education, WHO recommends 3 levels, and this goes back to the WHO resolution: basic training for all medical and nursing students and primary care practitioners. Around a week full-time, 30 to 34 hours is an estimate of what that might take. Intermediate level training, about twice as long, for all healthcare workers who routinely work with patients with life-threatening illnesses, meaning specialist trainees in internal medicine, oncology, hematology, pediatrics, geriatrics, oncology, cardiology, et cetera. And then specialist training we don't need a lot of specialists everywhere, but we do need specialists who are the teachers, the implementers, the clinical leaders for every country. So one of the important projects for the future is to grow these specialist leaders around the world. Next slide, please. The human resources are recommended to be deployed as shown here. Referral hospitals, ideally with a multidisciplinary palliative care team, ideally led as soon as possible in the future by a specialist doctor. And we recognize that many countries don't have specialists yet, but that's something to aspire to. And they should provide inpatient and outpatient services for the complex cases and to initiate palliative care before transfer back to lower levels. District hospitals might have a small palliative care team of part-time doctors, nurses, social worker with intermediate level training who also can provide inpatient, outpatient palliative care for less complex cases. Community health centers, sometimes with a doctor, often only with nurses, they should have at least basic level palliative care training to provide outpatient care. And if they're staffed 24 hours a day, possibly some inpatient hospice care for people living in their community if the family isn't able to take care of the patient at home. And then community health workers can be extremely important for palliative care, to keep an eye on patients, visit them at home, provide emotional support, and recognize and report any symptoms or any kind of suffering, social, emotional, physical, that is inadequately controlled, and report that. In some places, like in the Russian Federation and CIS, mobile teams are used instead of community health workers. Next slide, please. Last slide, I believe. This shows data from the Lancet Commission. So with data from 2015, we calculated the cost of making universally accessible the essential package of palliative care that I just described for everyone in need in 3 countries. 1 low-income country, which was Rwanda, 1 lower middle-income country, Vietnam, and 1 upper middle income, which was Mexico. And if you look at the fourth line from the, the bottom line, the very bottom line, in Rwanda, providing the essential package of palliative care for everyone in need in Rwanda would have cost around 9% of the total public health expenditure. In Vietnam and Mexico, it would have been 1%. And as we know from Eve's slide, there's many countries have a lot of out-of-pocket expenditure. But if this was if the entire essential package of palliative care were covered by public health insurance, that's what it would have cost in 2015. So only 1% of the budget in middle-income countries, around 9% in the lowest income in a low-income country. I think that's the last slide. Next slide.
We put a recommendation.
Recommendations. So ensure that for ministries of health, ensure that the healthcare providers in the country have access to all components of the essential package of palliative care. And very importantly, that everyone who has, all doctors, nurse practitioners, clinical officers who have basic training in palliative care should be allowed to prescribe controlled medicines, including morphine, for inpatients and outpatients. And then the ministers are advised to review the WHO technical guides and the guidance documents for integrating palliative care into healthcare systems.
Okay, thank you.
Thank you.
Thank you very much, Eric. We're going to move now to Eleanor Reid, who will talk about the evidence that palliative care can reduce financial burden on health systems.
Thank you so much. I'm delighted to be here. So next slide, please. We'll jump right in. So I'd like to start by talking about the 3 ways that palliative care can offer cost savings to a health system. This is through shorter hospitalizations, surrounding the patient and patient-centered care, thinking about goals of care discussions and discharge planning that enable shorter hospitalizations that are in line with patient wishes. And similarly, fewer high-cost, low-value treatments, really with a focus on beneficial treatments. And then finally, reduced repeat hospitalizations because of the 2 aforementioned points, and also through improved pain and other symptom control. Next slide, please, Liz. There are also macroeconomic benefits to society, and I know that many of you here in the audience are already aware of these, but we'll just go over them. So first, there's the possibility of both the patient and a caregiver to return to the workforce when their symptoms are less burdensome. Improved symptom control also can lead to improved mobility and functionality, and with downstream effects of improved quality of life, engagement in social activities. And then this next point is about reducing impoverishing health expenditure. And our next speaker, Jane Bates, is going to focus more on this, so I'll just touch on it. But decreasing this medical impoverishment can lead to improved caregiver and family quality of life. And then next, this last point, looking at the long run, long-term beneficial effects of a better end-of-life experience for family access to bereavement support, looking at long-term well-being for family members. Next slide, please. We have 2 country examples here. The first is Ethiopia, and next we'll talk about India. But in this, using Ethiopia as a country example, so in 2017, there was a needs assessment that I worked on with Ethiopian colleagues, and found that over 90% of cancer patients in Addis had moderate to severe pain. This was in a facility with access to opiate analgesia, and almost 25% of them were not prescribed any analgesia of any form. We also found in this same population that patients were unaware of their diagnoses and their prognoses, and selling major assets like farmland, wedding gold, pulling children out of schools in order to pay for medical care that was largely futile because it was so late stage. So this project was followed up with a feasibility randomized control trial looking at palliative care in the same cancer clinic. Palliative care started at the time of diagnosis, and we found that palliative care could be provided at relatively low cost, so $19 US for duration of care, breaking down to about $9 per visit. And that lower cost is compared to, of course, medical treatments, standard medical treatments. Next slide, please. We'll move on to India. Thank you. So I'd like to talk about 3 different papers out of India. The first was a systematic review of 22 studies that all took place in India, looking at financial toxicity and this concept of medical bankruptcy that results often from seeking cancer care. These authors found that medical bankruptcy was more common in the poorer sectors of society, probably not surprising, and that it was associated with poor quality of life, premature entry into the labor market, and also non-compliance with oncologic treatment. 60% of households in the private sector incurred out-of-pocket expenses, cash payments at point of service that were greater than 20% their annual per capita income. And then finally, 29 million households in India sustained catastrophic health expenditures for out-of-pocket payments. And this pushed 38 million people into the poverty cycle. And that poverty cycle is, again, something that will be touched on by our next presenter. I believe that was my final slide. Oh, the recommendation slide. So at this point, our recommendation is for ministers of finance to review the evidence supporting both the macro and the microeconomic benefits of palliative care, and then take the necessary steps to ensure that funds are available to support the initial implementation of publicly available palliative care in their home countries. Thank you.
Thank you very much, Eleanor. We're going to move now to Jane Bates. Jane, would you go ahead to talk about cost savings to patients and families?
Thanks, Liz. Thanks to EAPC and WHO for hosting this webinar on Universal Health Coverage Day. Great way to mark the day, I think. I just want to acknowledge the fellow authors for this presentation, Dr. Reid, who presented before, and Dr. Bactran from Vietnam. Next slide, please. So we're just going to briefly talk now about cost to patients. And a number of people have talked about the issue of whether palliative care can contribute towards poverty reduction in households. And this is a particular interest to national governments as they set priorities. As Eric said, not only looking at the medical and moral arguments for palliative care, but ensuring that we have a robust economic argument as well. So as we think about out-of-pocket expenditure and whether it decreases for patients who are able to receive palliative care, we have to think about what those costs might be, how we're going to measure those costs, what health systems palliative care is being delivered in, and what models of palliative care are possible and relevant in our different settings. Next slide, please. So if we think about what costs, if we go to the next slide, Liz, just thinking about when somebody, an individual in a household, suffers from ill health, there's a whole range of costs that might be incurred, not only from traveling to the hospital and gaining access to medicines and tests and inpatient stays, various other things. And those are called direct costs, but the indirect costs are known to be significant for many health conditions. And this is nonetheless true for patients with life-limiting illnesses, cancer, and beyond cancer diagnoses, which are causing life-limiting illness. Indirect costs are those which prevent people being active in the workplace. So they're losing time in which they may be gaining income. And people meet these out-of-pocket costs in a variety of different ways, through different coping strategies, borrowing money, selling assets, as Dr. Eleanor Reid just mentioned, and rely often on a wide variety of social networks and loans from a variety of settings where they live. Next slide, please. And we can sometimes think of the out-of-pocket expenditure impact in a setting of a poverty trap. So as household income reduces, that has an impact on reducing household capability and well-being. And this results in low level of education and training. And our first speaker mentioned other vulnerabilities that households and young people are exposed to. And this subsequently can contribute towards late diagnosis of life-limiting illness. So this is where, at this stage in the cycle, we want to see a palliative care contributing to stopping this poverty cycle, poverty trap, by improving function and enabling patients and or family members to return to work depending on the stage of illness and their ability to control pain and symptoms. Also critically reducing discrimination which may result from their life-limiting illness and their ability to function within the communities and societies of which they are part. And of course, aiming to reduce non-beneficial costly care, which has been mentioned already. So in this way, we're hoping that the impact of palliative care is to prevent forward movement into those high levels of catastrophic costs, which then reduce household income, and the cycle continues. Next slide, please. And particularly when we think about health systems, we have to think about the health system in which palliative care is being delivered, and the three components of universal health coverage are worth understanding a little bit. So looking at access to care, looking at quality, and looking at financial protection. So as we think about the economics of palliative care from the patient and household point of view, we're particularly wanting to speak to this element of financial protection. And it's one of the measurements that is being used for at country level to map the success of implementing universal health coverage. So it is really critical for us in palliative care to be describing impact in terms of financial protection on households, which is measured in terms of catastrophic expenditure and impoverishment. But clearly, if one is in a fully funded, maybe by taxation or insurance, a fully covered health system, then households are less likely to incur significant out-of-pocket expenditure. And it has been proposed that in a high-income setting where everything is provided through taxation, then a move to home-based care from a hospital setting may actually increase costs to patients and families. So we have to remember that and consider that and measure that. But in many low and middle income country settings, where there are many gaps in health financing, which have to be met by out-of-pocket expenditure, we can consider that palliative care and access to care, as Dr. Reid mentioned, and this reduction in non-beneficial, particularly costly care towards the end of life, can help to reduce the out-of-pocket expenditure for patients and families. Next slide, please. So this is my last slide, just thinking about models of care. I think some people on the call expressed an interest in trying to understand what was the right model to use. And I don't think that there is a right model in terms of economics. Different palliative care is required at different levels. So here, this is from the excellent recent World Health Organization publication looking at and outlining a set of actionable indicators for palliative care, using a sort of model of a house for us to think about palliative care delivery and development. And they talk about primary level palliative care and specialist level palliative care. Obviously, if you're delivering a community service with outreach, you're going to reduce transport costs for patients, and you're going to enable people to stay in work for longer. But then those models of care are going to access much larger number of people. So their economic benefits will sit there. But also as patients access specialist level care, and if we think about going into an intensive care unit and very high levels of care, which may be non-beneficial and can be very costly, if we think towards an integrated model of palliative care at a specialist level, there's a great potential to reduce out-of-pocket costs for patients and families. And just briefly to mention some of the research which I've been involved with in Malawi, we looked at 150 households that were accessing palliative care within a hospital setting, and catastrophic expenditure was reduced from 69% to 47%, and there was a significant reduction in levels of saving for those households. Some research has been done. I would say it's still at a relatively early level, and multi-country studies are needed to ratify some of the methods that were used and the tools, and to get even more robust data to support these arguments. Last slide, please, Liz. So a recommendation to Ministers of Health and Finance for them to recognise the health economic argument for publicly accessible palliative care, offering cost savings to households, and thinking about it in terms of a poverty reduction strategy. Thanks very much.
Thank you very much, Jane. We now have Richard Harding, who's going to talk about how we improve patient outcomes through quality palliative care, because the argument needs to be not only do we save costs, but we improve outcomes. Richard, over to you.
Thank you, Liz. So if we can move on. So this is really important. The word quality has run through all of the presentations to date. So let's look at this report from the WHO. Really important. Quality health services and palliative care. Says very clearly, delivery of quality palliative care is a moral imperative and a human right. Quality health services and palliative care are inextricably linked, vital for the achievement of UHC. So what is quality healthcare? Well, the model that I usually go to is Donna Bedian's model for quality of care. So we start off with structures. So what have we got in place in the health systems, palliative care teams, hospices? Then the processes, what do we actually do with them? What services do we deliver? And then really importantly, as a result of having those structures in place and delivering care, what outcomes do we change? What healthcare can we demonstrate makes a change on the status of patients and populations? So this is really crucial, because if we're going to suggest that palliative care is cost saving, then we need to demonstrate that it's cost saving while improving patient outcomes, because of course we need to be very clear in our defence against the argument that palliative care is second-class care as withdrawal of treatment. If we don't measure outcomes, we can't show that while we're saving money, we're improving costs. So outcomes are absolutely key. Thank you, Liz. Next slide. And why is this so important? Well, here's the numbers. From 2016 to 2060, using the WHO mortality data, you can see the increase from the top, low-income countries, then lower middle, grey, upper middle, and then high-income in blue countries. These are numbers of people dying with serious health-related suffering. So this is an absolutely enormous increase, almost doubling. And in fact, for low-income countries, it's over doubling. So that's an absolutely enormous amount of care. So if palliative care is cost saving, if you consider how much it would cost if you didn't have palliative care by 2060, then that's an enormous amount of the health system spending on the last year of life. And we could make an enormous dent on that cost whilst improving patient and family experience of care and outcomes of care. Thank you, Liz. So measuring and improving quality is absolutely at the heart of considerations of costs and health economics in palliative and end-of-life care. Several people, including Eric, have mentioned the Lancet Commission key document, which stated very clearly that the use of outcome measures in palliative and end-of-life care are crucial in informing both care that we deliver and policies that we enact. And then the other excellent report on the indicators, the actionable indicators for palliative and end-of-life care, talks about measures being really important in determining effective service coverage. Now, effective really does require us to think about outcomes, because we can't say it's effective unless we've demonstrated at the patient level that we've improved health outcomes. So that report makes reference to explicitly defined and measurable metrics that help in the assessment of structure, process, or outcomes. Now, I think a lot of the work in that report has done fantastic work on structures and processes, and now it's time for us to think more about the outcomes that we need to measure. And we have to use specific measures for palliative care, because what people measure in other areas of the health service or standard quality of life measures don't always measure the things that matter to our patients and families facing progressive illness. And a good example of that is this review by Dayo Afolabi, PhD student with us at King's, who recently graduated with his PhD. And this systematic review did a nice overview of the evidence for the needs for people in sub-Saharan Africa with serious physical illness, and showing that actually there are very, very specific outcomes that we need to measure. So we can't use ordinary generic measures. Next slide, please, Liz. So what we can do if we start measuring outcomes and costs, then what we can do is cost different ways of delivering care that reflect patient outcomes. So if we achieve this improvement in pain and symptoms, what will it cost us? What will the cost saving be? But also, once we start measuring outcomes and costs and classifying our populations, we can really understand what the different costs of care and trajectories of care will be for different combinations of patients in the service population that we see. So trying to group patients and the costs and the outcomes according to maybe disease stage, the disease fluctuation and how stable they are, the condition that they're living with, and their physical function. So once we start to really measure outcomes, so here's an example of the work that Fliss Mertens led, measuring case mix classifications in palliative care, so that we can really understand this in better detail, because I think Eve started this seminar by talking about the complexity of patients. Now this really starts to understand that complexity. Thank you, Liz. So here, I just want to end with this example of how simple brief valid outcome measures work in routine practice. Here's the fantastic team with Liz Namakwaya at Malago Hospital in Uganda. For 10 years, they've been using the African Palliative Care Outcome Scale in routine practice at Malago. They use this simple measure of patient outcomes in all of their clinical assessments. It helps them very quickly to decide which outcomes they need to prioritize, because they can see what matters most, where they can lead their further in-depth assessment. It enables them to identify which members of the multidisciplinary team need to attend the patient, but also what training they need and how they should develop their services in response to patient need. And it's also really, in their view, enabled them to deliver really, truly patient-centered care and get access based on need, which is the most important thing, isn't it? Access to palliative care based on need. So they're a really good example of how outcome measurement is driving their care, very, very simply. Thank you very much. I'll leave you with that recommendation to read as Liz introduces the next speaker. Liz?
So I'm going to now talk about the framework for funding palliative care services, because really, if you think about the World Health Assembly resolution, countries are determined that there should be palliative care, and countries have committed to funding palliative care. But it's the how is this going to happen? And my fellow presenters have presented the evidence on cost savings, the evidence on effective models of palliative care, and the evidence for patient outcomes. So the funding mechanisms that we have to consider is that palliative care is a component of universal health coverage. And as such, funding is likely to be pooled with other universal health coverage, such as government funding or insurance mechanisms, which may be public insurance mechanisms or private insurance mechanisms, and may be increased by donor or charitable funds. And quite in many countries, charities, the NGO sector, such as hospices, are really important places of palliative care, or organizations that provide palliative care most often in the person's home, but they also need these funding mechanisms in order to be able to provide those services. And one of the key things, that messages that we have been trying to get across, is that funding of public palliative care must avoid significant user fees and must minimize the risk of catastrophic costs to the families. This is a time of life when people are not able to gain an income to pay for care. So their care needs to be provided in the public health sector. So what are the funding strategies? Really, the foundational step is to include the training of all healthcare workers in palliative care, and especially, as some of my colleagues have spoken about, in communicating prognosis and treatment options, and in the use of indicator tools to identify patients who would benefit from palliative care. Really, we are hoping to reduce non-beneficial treatments. We are not able to say this treatment will work or won't work. So it may be that there's a trial of therapy sometimes, but if it's not working, then it should be, that treatment should no longer be offered. So when we provide incentives for more efficient use of existing healthcare resources, then we may find that we're getting savings accrued from the avoidance of non-curative treatments that can be shifted to palliative care. And we need also to provide incentives to integrate palliative care into the existing health infrastructure and generalist care. And this may not be financial incentives, it's looking at, are we providing a better service to our patients and our communities by making sure that every health facility has palliative care available for people who need this. Daniela Masoy has provided for us the example from Romania, that palliative care in Romania started from the non-governmental sector in the hospice, with services being financed initially through charitable donations and international grants. Then a funding mechanism for funding palliative care inpatient unit in a public health facility included palliative care in the national frame contract in Romania, financed through the Romanian National Health Insurance Systems. And it was motivated by a costing process conducted both for home care and inpatient services in 2010. In 2016, the government acquired World Bank approved loan for the reform of the regional strategy for palliative care was developed. Currently, palliative care in Romania is funded by a consortium of national stakeholders, the Ministry of Health, the Ministry of Social Welfare. As Eric said before, there needs to be both of those ministries involved in care funding, the Agency for Quality and Healthcare and the National Insurance House, and then the Hospice Casa Sperante. And I'm very aware that a national strategy for palliative care must be backed up by funding, because where I come from in South Africa, we've got a wonderful national palliative care strategy, and it doesn't have a budget attached. So this is an important thing for governments to look at. So the recommendation is that country leaders, the Ministry of Health and Finance, should work collaboratively to apply funding strategies that will finance public palliative care delivery and understanding the intervention as a value added to their health system and a poverty reduction strategy, as has been discussed earlier. And the summary slide, and thank you, Eric, for providing this for us. The integration of palliative care, including home care, into public healthcare systems appears not only to improve patient well-being and support patient preferences for place of care, but to reduce overcrowding in referral hospitals, to provide financial risk protection for patients' families, and to reduce the costs for healthcare systems by reducing dependency on hospital inpatient and outpatient services, that the home care and the community care can provide quality care that the patient needs. Therefore, any initial investment needed for hiring and training the adequate human resources and the cost of transport for home visits may result in cost savings. We're certain that it will result in cost savings, but we're just putting the caution in there in recommending to governments. So greater investment in palliative care services by governments and funders going forwards has the potential to improve quality of care for patients while economizing on healthcare expenditure. And I'm just going to show you, and I know that Joanne has put up a number of resources that you can use, some really excellent videos that are good for awareness and advocacy, and then the WHO publications, some of which have been referred to during this talk. But I do thank you for your attention. I thank EAPC particularly for hosting this webinar. Marie-Charlotte and I are really grateful for the opportunity of showcasing the work that this group has been doing on developing the paper for on the economics of palliative care. And we hope that early next year it will be released and can be used in country to work with governments to improve the funding for palliative care services. So thank you very much. And we're going to open the webinar now for discussion. And again, that's one of my jobs to open the discussion. So I'm going to go to some questions that were sent to Joanne as people registered. One is, kindly share costings for palliative care models of service in settings where healthcare costs need to be met out of pocket. And I think that, Eric, you did a lot of work with this on the Lancet Commission, and I'm not sure if Eve's been able to join us, but there are a number of people who could respond to that. But I'm going to ask you first, Eric.
So the question is about out-of-pocket expenses?
It's how to share costing. How did you do the costing of palliative care services in countries where mostly healthcare is from out-of-pocket expenses?
Okay, yeah, we just, again, we created, thank you for the question. We created an essential package of palliative care that I described based on the estimate of the need. And in 3 countries, we found the cost of each item in the essential package for hospitals, not the price to patients, but to hospitals. And also that included the staff salaries. We had an estimate of the numbers of each type of staff member, from social workers, psychologists, nurses, doctors, and how much time they would need to spend, and every item in the package. And we found what each of those cost in each of those countries. And then we did the calculation of what percentage of the public healthcare expenditures in the 3 countries would be needed to pay for that. So as I mentioned, the low income country that we studied was Rwanda, where I just came from yesterday, and it was close to 9%. But again, one has to recognize the great potential, the likelihood of cost savings. So yes, the country might have to spend 10% or 9% of their healthcare expenditures to make the essential package of palliative care universally accessible, but that would end up in cost savings in other places. Thanks.
Thank you very much, Eric. I'm also going to go to the Q&As and to say thank you very much, Catherine. You've given some very thought-provoking questions, initially looking to see, are we able to address the environmental benefits as this is a major priority of member states looking to reduce their carbon footprint. It's not something that we'd specifically looked at in this paper, but it may be something that we should consider. And I see, Jane, there are two questions for you. I see you answering Catherine's question about the fact that caregiving is deeply gendered, which deepens the poverty cycle. And Catherine talking about she tries to integrate a gender perspective into advocacy for palliative care benefits at clinical and financial levels. So Jane, I'm going to ask you to answer that one from Catherine and then go on to a question that's been asked about Malawi, because I see, Jane, you're busy typing a reply to Catherine.
Thanks, Liz. Thanks, Catherine. Very interesting about carbon footprint. That's something really to think about, and as you say, critically important across the board as a cross-cutting issue. In terms of caregiving being gendered, I was just thinking in our study, I think over 70% of caregivers were women, and it's sort of a reminder to me to try to publish some of that data, because we did look at quality of life of caregivers, and we do have some demographic data about those caregivers, age, sex, socioeconomic status, and we looked at quality of life from time of diagnosis to 6 months. So I think there's some data around that probably I need to be a little bit more diligent in digging out and publishing. So thank you for the inspiration to do that. The next one, you wanted me to talk about Malawi? Yeah. So I'm not sure if everybody can see, but I'll just read out. It says, from Malawi, I've been told by clinical officers in Malawi that palliative care patients have the right for unnecessary laboratory tests, inappropriate procedures, etc. How can this issue be addressed? I mean, it's always tricky, isn't it? I think we tread a cautious line, as I think Richard said, you know, that palliative care is not no care, and it's not withdrawal of everything. So for those of us, I think, who've been involved clinically in palliative care, we definitely want to deliver the most appropriate high quality care for patients, and that may involve laboratory tests, and it may involve procedures, and palliative care involves all those things. So I guess it's around the word unnecessary, and there are times when people persistently choose to we've had patients wanting to fly to Tanzania for radiotherapy when clearly it's been at the end of life, and you have to continue supporting people with their requests and their requirements alongside. A lot of it's about communication and developing that therapeutic relationship, because you know, you're dealing with somebody with their own understanding of their illness and supporting them within that. So it's tricky. There's no, you can't say, oh, you've got palliative care, you don't get this, you don't get that. It's about navigating those tricky things along the way, and having evidence, supporting the patient, supporting the family members, giving them information. I mean, I'm sure others on the call can contribute to this as well, but in terms of having the right for investigations, then I mean, people do have the right for healthcare, and we're not denying that in any way in palliative care. It's just trying to make it appropriate and truly beneficial to quality of life. So I think it's the door opens with communication, and it continues with communication, and it ends with communication, really. And so communication is the key. That's what I'd say. Thanks, Liz.
Thank you very much, Jane. Richard, I'm going to go to the next one, which is a question from Indonesia, which is talking about, usually in Indonesia, only patients who's already at the end of life will be referred for palliative care, and that palliative care isn't covered by universal health coverage or funding. So they say that they have difficulty to study the real benefit of palliative care. Do you have any recommendation to start a study or initiate palliative care implementation so that we can propose that it's being covered by universal health coverage? This paper is a foundation that you can take forward, but Richard, is there anything else you would advise on studies, the benefit?
Yeah, I mean, the first thing I would say is you're not alone in Indonesia. You remember in the US, it has been a long-standing challenge that you can only claim hospice benefits in the last 6 months of life. So don't feel that Indonesia, you are alone in that. And we globally face the challenge, I think, of early integration. And Eleanor, of course, has been doing that work in Ethiopia. So what I would suggest is you try and create yourselves a demonstration project. So while there may not be a benefit, if you can do some initial piloting work and you can evaluate it and you can show that you're improving patient outcomes, and you can draw on the global literature which shows cost saving and patient benefit, then you should be able to construct a good argument. But those good arguments, of course, are often won by the absolutely amazing advocacy groups around the world. So WHPCA, IAHPC, and national associations. So it's about that strategic link up of powerful voices using the existing evidence and demonstrating that you can do. I think Eleanor showed earlier in her feasibility study, she showed that it was possible and that there's a potential cost saving. So I think what you need to do is find a way of funding a pilot study and then using that as a demonstration project from which you can try and move outwards into the health system, if that's helpful.
Thank you very much, Richard. I'm going to move then to another question that is saying, any thoughts on palliative care and dementia? And I do know that EAPC has done and is continuing to do great work on developing models of care for palliative care and dementia. I'm sure a number of our panelists are busy with that. But would anyone like to comment from the panel on their thoughts on palliative care and dementia? I mean, it's an essential component of dementia care.
Well, Liz, I could make a couple of comments.
Thank you,
This is Eric. But before getting to dementia, I just want to, if I could, follow up on Jane and Richard's comments and the question from Indonesia. I think it's very important to make clear that palliative care is not an alternative to disease treatment. And therefore, I don't use the term palliative care patient. I don't know what a palliative care patient is. That could mean a million things. Palliative care should be integrated often with disease treatment. Sometimes, as we know, it can improve outcomes. It may even improve the potential for cure. So it's about integrating palliative care with disease treatment. I guess I would just also add, in the question about deciding what treatments should or shouldn't be used, that context is so important. Palliative care varies depending on the needs of the population being served, and they're very different values. So in Confucian cultures, for example, in East Asia, where there's the very powerful idea of feeding and caring for older people, and it's interpreted, filial piety is interpreted as keeping them alive as long as possible. That needs to be understood and to be appreciated in negotiating the idea that maybe you can best show your filial piety by protecting your dying elder from invasive life-sustaining treatments. With dementia, it can be not only a very terrible for patients, but a huge problem a huge burden for caregivers, which, as Jane mentioned, are typically women, often girls. And it can lead to health problems, physical and emotional, for caregivers. So depression, anxiety, and other problems related to exhaustion, demoralization are very common in caregivers. So I think that part of the work of palliative care is to identify the specific needs of specific populations. With dementia, caregivers are very vulnerable. with stigmatized populations, women with cervical cancer and breast cancer who are often abandoned by intimate partners, and stigmatized people with stigmatized diseases like HIV, tuberculosis, requires special attention from palliative care providers. Thanks.
Thank you very much, Eric. I'm going to initially answer Linda's question, where her organization Aligned in South Africa, she says, in Aligned experiences, funders of healthcare do not perceive a business case for early referral to palliative care. Any input would be appreciated. So I'm first going to comment on the fact that one of the things that the paper talks about is the high cost of care in advanced illness and in the last year of life in particular. And that one of the reasons for this high cost of care is because clinicians may be uncomfortable or not familiar with or not skilled in communicating poor prognosis, and may also not be skilled in identifying that the patient should be being treated more with palliative intent than with curative intent. So to me, the first thing is awareness raising and education of clinicians, and making sure that there is a tool or a questionnaire, that's something like a supportive and palliative care indicator tool, and then to show that by avoiding the high cost, expensive hospital admissions and treatments, that this is a cost saving for the health funder. And we need to be very careful about not saying we are, as Eric was saying just now, we're not, and Jane was saying about in Malawi, we're not denying treatment to patients. We are looking with the patient at what the treatment options are so that they and the clinicians can make the best choice possible. So I'm not sure, Eleanor, Eric, would you like to comment further on the benefits of early palliative care, the economic benefit to the funder or the health insurance company? Eleanor, would you like to answer that? Have we still got you, Eleanor? Are you?
Sorry, I froze for a moment. And I apologize in advance for background noise. I mean, I think this is really the crux of the matter here, getting right to it. And there is a growing body of evidence supporting the economic benefits of early palliative care. We have on this panel people like Jane Bates worked on this in Malawi and has those results. My Ethiopia results are very preliminary. And as you said, Liz, this is really about the costing mechanism is really about looking at what this offers to both health systems, but households when they avoid low value, high cost care. And so it's about adding value to medical care by avoiding futile, non-beneficial care. And I think the WHO has a number of technical documents about implementation strategies, and I think the financial evidence is it's emerging now, but is early. Yeah.
Yes, thank you very much, Eleanor.
So I would refer again to the study that Jennifer Temmel did in 2010 that I think changed all our lives, which showed that not only did patients live longer, they also, the patients who got early palliative care at the time of diagnosis of metastatic lung cancer, compared to patients who didn't get early palliative care, they lived longer, they had less depression, and they were less likely to get chemotherapy in the last 2 weeks of life. So there's, if I'm an insurance company executive, I'm thinking, oh, we should be offering palliative care because then they won't be getting expensive chemo. Of course, if I was a drug company rep, I wouldn't like it too much. But yeah, I think there's evidence, as Eleanor was saying. Thanks.
Thanks, Eric. And Peter, you've got a comment.
Yeah, well, I only wanted to add to what Eleanor was saying, that, I mean, there's in the clinical literature, there's the Temmel paper, and we found consistently in work we've done and others have done that timing is critical, because you accumulate the costs over time. So if you take a single hospital admission, the cost of that admission starts the moment you enter the hospital. Where if you only get palliative care on day 5, day 10, then you've accumulated most of your outcome before the treatment can impact it. And so there's a sort of a self-evident logic there. And I think you can apply that logic across whole episodes of care. In low and middle income countries, we're thinking about a different context, but that's inescapable fact that costs accrue over time, and there's a pathway effect wherever you're receiving healthcare. Therefore, what you've had leads, if you've had more in the past, you're more likely to have more in the future. And so therefore, earlier interventions are almost always going to be more cost effective in appropriate populations, everything else being equal.
Thank you very much, Peter. I'm going to go to this comment from Albania, Albana Poloska, saying in Albania, there are only 2 charity centres that offer palliative care, but there are a large number of patients that need this service. Yes, we're so aware of that. What do we think about forcing nursing roles in primary healthcare centre so that they, I think that, to me, and what I said in part of my presentation, is the foundation is education. So it's really the advocacy to make sure that nursing colleges and medical schools and nursing schools have palliative care. So Eric, you were talking about the number of hours that we needed for basic and intermediate palliative care. And of course, Albania was one of the countries that signed up to the World Health Assembly resolution that says all healthcare workers should be trained either at basic, intermediate, or specialist level. And our experience, I think I talk for all our panelists, is that once somebody has been trained in palliative care, they can implement it. And a lot of them, a large majority of people, will themselves become advocates for palliative care. Would any of my panelists like to further comment on this?
Yeah, Liz, I would emphasize the last thing you said. There's been a lot of palliative care training around the world. And in Rwanda, for example, where I just came from, there was a lot of training for every district hospital in the country, and there's very little palliative care being done. So training, yes, training is important, but I think there needs to be policy that makes palliative care part of the job description of all the multidisciplinary team of doctors, nurses, social workers. It's got to be a requirement. It's got to be part of the job description. They have to be paid for it, and they have to be enabled. They have to be able, doctors need to be able to prescribe morphine. It does no good to teach doctors the details of opioid analgesia if they're not allowed to prescribe it. So I think training, yes, but training for staff who will be able to use it and try to make sure that whoever attends the training will be enabled and empowered to use it. Thanks.
So our colleague from Albania, this forcing is making sure it's part of everybody's job description, as you say, Eric. Jane, you've got a comment to add.
I mean, just, I suppose, experience from Malawi when we were starting out and there were very limited services. Sometimes if you can access key people in the ministry, we had a very supportive desk officer at the Ministry of Health who fairly quickly, she carried with her a kind of passion for palliative care. So that was massively helpful. And also through APCA, I think in the early days, we had some funding for a couple of key people in ministry to visit Uganda to look at their production of oral morphine, to look at the difference that services were making. Obviously, Albania is within a European context, but if there's some ministers that, or people within the ministry who are sympathetic and who can visit kind of model services and get a sense, because everybody knows from their family about people living and dying well and living and dying badly. So it doesn't take much to key into that sensibility in people's minds, but you have to find people who are active at ministry level So, and it doesn't take many, but more than one. You need a little cohort of people who are going to be on your side, who are senior people. So that's just an idea from Malawi. Thanks.
Okay, thank you very much, Jane. There are two questions that come about sharing how to do the costing. And one coming from Ghana, and I'm just going to first comment on the fact that the African Palliative Care Association has done studies to look at costing, and that investment case in Kenya is a really good example to look at for costing palliative care. But of course, Eric with the Lancet Commission did that very in-depth costing. And this question of would you share the methodology with our colleagues, Eric?
Yeah, absolutely. It's I think it's all in the appendix to the Lancet Commission, which is available online. If you go to Lancet Commission on Palliative Care, I think you should be able to find it. I think it's open access now, and it's a bit complicated to explain here. It would take too long, but it's available. It's described in the report, and the details are in the appendix, which is available online. If someone could email me if there's I could provide.
Or we can ask Joanne to share it with all of our attendees. We'll put it through EAPC.
Thanks.
Okay, thank you. So here's another comment that there's a big difference between government health system economics and hospital economics. What methods are there to convince hospital directors that palliative care is worth investing in? Who wants to take that one?
Well, that's a really good question, because hospitals are funded in different ways. So there are countries where hospitals have incentives to admit and keep people in the hospital, and disincentives to discharge people and to try to keep them out of the hospital, because they're funded by how many people they admit. Yes. So the incentives that are set by the government are crucial. This is a problem, I think, in the Russian Federation and CIS countries, where hospitals have incentives to admit people. So I think it's a question of incentives, and some of the economists will be able to speak to this more intelligently than me. Thanks.
Well, maybe we should ask that. I don't know, Peter, if you want to respond, because the person asking the question has made that specific point, that in fact decreasing hospital stay and ICU admission may be profitable to the funder, but not to the hospital. So how do we make sure that hospitals will also include palliative care? Peter, have you got a comment there?
Well, I mean, I think what Eric has said is basically right, that a lot depends on the context, and even within a specific hospital, they'll get money in lots of different ways, depending on how the health coverage is funded. I mean, the sort of the short, slightly cynical perspective of, like, for a summary of what happens in the United States, for example, is that because there is a clear connection between having a hospital palliative care team and reducing the costs of patients for whom you still get, or in the historically, the income you get for those patients has stayed fixed, made it relatively easy to incentivize, well, not relatively easy, took an awful lot of work by a lot of people, but that was a key part of the story in how American hospital palliative care teams spread, that it was a simple improve quality of care and increase their profitability decision for senior hospital management. I think that changes a lot in other jurisdictions, and of course, as other people have said about other aspects, for example, the growing unpaid care burden and the gendered nature of care burden. I mean, a thing that always worries me when we only take a hospital perspective is it's great if people are out of hospital earlier getting care they don't need, saving the system money, but they still likely have needs, and those needs are being pushed onto somebody else. And when we do hospital-only studies, we miss that very important perspective. So I think it's harder to go into more detail without knowing more about the specifics of how the hospitals are financed, but the story is generally easier to tell if they're paid a fixed income based on, for example, primary diagnosis or DRG, because then if you can reduce the cost but the DRG payment is the same, then that's an easy formula.
Cool. Thank you, Peter. And then the next question from Tilo Govender, who I know well. Hi, Tilo. Should there be a country-level scorecard for palliative care that looks at education, training, policy framework, drug availability, and access to palliative care? So there is. One of the resources we've been talking about this afternoon is a WHO document called Assessing the Development of Palliative Care, a set of actionable indicators. And that document does actually measure what's in place and what's not in place and what needs to be in place. So if you look at the end of our slides, and I think Joanne has been sending out the resources, and look at some of these resources, it would be really helpful to see, for example, how we measure our country. And in fact, the lead authors of that document from Spain, in the collaborating center with WHO, is actually starting a pilot project to look at how practical this set of indicators is. I don't know, Marie-Charlotte, if you want to say anything more about the pilot for the indicators.
No, maybe just to say that we actually do want countries to include this kind of evaluation in their regular evaluation of health programs in general. So I think it's very important to be familiar with the technical tool, and also we will circulate the result of this pilot project in countries. It's important to express also the interest for doing this, but the whole purpose is really to empower countries and train them so they are able to do this regular evaluation of the quality of palliative care. And I think this is certainly an important element in this discussion. As it was said by our panelists, if we don't know exactly what we do and what is the outcome for the patients, it's difficult to invest in this area.
Thank you, Marie-Charlotte. At the end of our webinar, there are a couple of questions that was also sent to Joanne that we would try to answer, but this, you'll have access to the webinar. We're hoping the paper will come out early. We're planning for it to come out in March next year. And one of the comments has been, what's the best model of palliative care in low middle income countries or in any country? And I think that if you look at the WHO resources, if you look at what is recommended in the essential elements of palliative care that came out of the Lancet Commission, I think that would be very helpful. But I want to say, before I hand over to Marie-Charlotte, thank you very much for attending this webinar and for your very thought-provoking questions. I think that it's been useful to have this webinar before we finalize the paper, because I can see there are a couple of important points that we should actually add in there. So thank you very much indeed. And over to you, Marie-Charlotte.
Well, thank you, Liz, for this conversation today and for all the work you have been doing with the expert group. I feel privileged to work with all of you on this important issue, and I think the participant of this webinar would agree with me in saying that you managed to clarify important points and also to open, as you just said, Liz, further reflection. I think it's extremely important to insist on the fact that palliative care is not an alternative. It's just a way to end with vicious circle. In particular, this circle when we are tempted to continue with unnecessary intervention or futile non-beneficial care while patients are needing other kind of interventions. So I think this is very important to insist on this message. What this conversation is adding is the fact that at the same time we improve the quality of care, we can be more efficient at the level of health services, and we can also help family caregivers and the community in saving out-of-pocket costs. So I think just 2 days ago, we celebrated the World Day on Human Rights, and we have to continue saying that palliative care is a fundamental human right. But at the same time, we now have enough evidence to demonstrate that this can be affordable. This is not just a dream. This is something we can do even in settings where resources are extremely limited. So our duty to do it is even higher, because we know this is actually realistic. I'm very happy to say that this conversation is not going to be closed. I think it's important to keep in touch, and I would even open more exchanges. So I know if participant wants to continue this dialogue or raise additional questions, they can do so, and we will try to continue this exchange with more specific dialogues if you wish so. So thank you all. Special thanks to our panelists today, and over to our colleagues from EAPC.